for having me, and I'm sorry not to be there in person and to jump in sort of in the middle, but I did look at the materials that were sent around, and I want to use the time I have to raise three questions that come out of my own work in community development with a particular focus on health equity. So the first question I wanted to talk about was, how can we ensure that community development initiatives designed to improve health contribute to shrinking rather than widening inequalities in health? And I know that's something that all of us who are working in this area kind of worry about. We know that community amenities like parks and better housing and healthy food stores and improved transportation and improved schools can contribute to increased property values. And how do we ensure that these increases in property values and amenities don't push poor people out because they can no longer afford them? Or something we've seen a little bit in some of the work I'm doing here in East Harlem, where our school is located, how can we ensure that these improvements don't create apartheid food, housing, and other kinds of markets, with one system serving the better off, the Whole Foods, the farmers markets, and another, the bodegas and convenience stores, serving poor people, creating very different opportunities for health. And in thinking about some of the potential solutions to this, I think one is on the process. One solution is the process we use to plan community initiatives. And I think by making sure that all sectors of communities, including those who are sometimes disenfranchised, are involved in planning and making decisions, we can at least minimize the chances that the improvements will benefit everybody and not just the better off. I also think, and here I sort of borrow from Paul Farmer and some of the ideas he took from liberation theology, that developing interventions that focus on the poorest and most vulnerable sectors, you know, what people in liberation theology call privileging the poor, is one way to ensure that those benefits spread. So for example, here in East Harlem, epidemiological studies have shown that the population that has gained the least from the improvements in longevity and health in New York City are middle-aged adults living in New York City Housing Authority facilities. And so a lot of the new efforts, both that our faculty are involved in at the School of Public Health and that the de Blasio administration is focused on as they look to promote equity, is to focus on populations like the NYCHA population. And I think a third approach to ensuring that benefits don't accrue only to the wealthy or the better off is to provide subsidies. And I know a number of cities have tried programs like the one here in New York called Health Bucks, that is a supplement to SNAP or food stamps that provides additional benefits to get fruits and vegetables for poor people. So if you're able to bring a farmer's market into a low-income community and the prices are somewhat higher, by providing some kind of subsidy, that you can make it available to more sectors of the population. And similarly, setting aside subsidized housing within new housing developments is a strategy that has been used to mix the benefits. I think what I'll do, because of my limited time, is just go through these three questions, and then I'm hoping we can have a little time for discussion. The second question that I wanted to raise is what role health professionals can play in finding an appropriate balance between market forces and the public sector in improving community environments in order to promote health. Many of the housing, food, healthcare, and employment problems that low-income communities face result from market failures and inability of the market to provide all sectors with access to healthy goods and services and products. So, for example, the ubiquity of unhealthy food in poor neighborhoods is a market failure of our food system. The classic solutions for market failure, such as information asymmetries, externalities, inefficiencies, is government intervention. And I think in several sectors, such as food, housing, transportation, education, the public sector and the market sector coexist, sometimes in partnership and sometimes in competition. But rarely, I think, have city governments and community development projects looked at leveraging the public sector in order to correct market failures. So I've been thinking about this a lot in terms of food. And there's a very robust public sector in food. I mean, I know about New York City, but I think it's also true in other cities. Institutional food. New York City serves 260 million meals a year in schools, hospitals, jails, daycare centers. And that has the power to change food environments, particularly for vulnerable populations. Food benefits like SNAP and WIC are an important part of the food retail environment. And so if we could encourage cities to think about the variety of tools they have in the public sector, all the different ways that taxpayer dollars and city services touch food, or in other cases, touch transportation, touch housing, and then to use those, to use that public sector in a focused way to promote community development and to reduce inequalities in health, I think we might be able to achieve more systematic results than the kind of laissez-faire approach even to the public sector that we see today. And the third and final question I wanted to ask is, how can we better integrate job creation, workforce development, and job training into community development initiatives? And I think the most urgent need for low-income communities is jobs, and especially jobs that have low entry barriers, but also provide a path into lasting jobs that pay a living wage, offer better benefits, and provide safe working conditions. And those are very tall orders because those things are often in conflict with each other. But I think it may be possible to develop interventions that meet this need of job creation or upskilling while also creating healthier communities. And some examples are community health workers. And I think with the Affordable Care Act and the development of patient navigators and chronic disease managers and community health workers offer a way to create new jobs within poor communities that also have other benefits to the community, improving health. I think the whole green job sector, and particularly brownfield remediation, lead and asbestos abatement, create entry-level jobs which, if done properly, can lead people into a sector where permanent jobs that are better paying jobs are available. And the third example, which is an area where I've done some work, is what we call good food jobs. The food sector is particularly promising for offering entry-level jobs, but not very good at providing living wages or good working conditions. And by thinking about jobs that could increase the pay and working conditions and also contribute to making healthier food available, we offer the possibility of improving health. So for example, I'm working with some folks at the City Health Department of creating certificates for home healthcare workers in nutrition and shopping and food preparation that would ideally enable them to make more money, but also to contribute to community health. So I've thrown out a lot of ideas, and I think I'll stop here and would welcome reactions and comments and thoughts.